first thing we'll start with is what's called the genetic sonogram, or as you may know it as the level 2 ultrasound, looking at the different details of the baby. What can we see with ultrasound? What are we able to identify? So I do want to give a special thanks to the genetic counselor, Rachel Clark, and then my perinatal physicians that I work with, because I had them, help me go over the slides, make sure I was presenting the latest, greatest material to you. So why are we doing this screening? Well, it's a patient-driven procedure. Fetal ultrasound is widely accepted and expected. Moms want to have that scan. They want to have that evaluation. Our patients are demanding more and more information. Patients want less invasive approach. So instead of having an amniocentesis or CVS, they want to have that screening ultrasound to see what their risk is, if it increases or decreases their risk. So we all operate on this baseline risk. So who do we consider high risk? Well, any mom who's going to be 35 at the time of delivery. That automatically puts them into a higher risk category. Anything below that is considered your low risk category. Other risk factors that we have is family history, pregnancy history. If they have any serum screening, any genetic serum screening, that may increase or decrease the risk. And then looking at the ultrasound. So a new risk is assigned using all available information, and this is usually assessed or performed by perinatologists or genetic counselors. A lot of times we're working with them, in conjunction with them, to try to give this patient a new likelihood ratio. So what are the risk status? We have low risk and high risk status. So low risk is anyone having a negative biochemical screen, or if no screen, when the maternal age is less than 35. High risk is maternal age, again, greater than 35 at time of delivery, or anyone with a positive biochemical screening. So if they have a positive screen, that moves them into the high risk category. So abnormal karyotype, it's important to remember what's the most common in occurrence versus live birth. So a lot of these babies or these fetuses that have abnormal karyotypes never make it to time of delivery. So the most common in occurrence is actually going to be a trisomy 16, and then Turner's, and then triploidy. The most common in live births is going to be trisomy 21 or Down syndrome. And then that's followed by 18, 13, and Turner syndrome. So rule of 6 is for abnormal karyotype. It's just important to remember that it accounts for about 60% of your first trimester losses have some type of karyotype abnormality. If a mom has more than 2 spontaneous losses, then you may want to check the parents' chromosomes, because they may have a chromosome abnormality, whether it's probably just a mosaic or a translocation, just a part of that genetic material is wrong. So if they have more than 2 losses, we do go ahead and do mom and dad's chromosomes. And remember, about 6% of newborns have structural abnormalities. So when do we screen? Well, there's first trimester screening and there's second trimester screening. So in the first trimester, from 11 weeks to 13 weeks, 6 days, we're actually going to measure the nuchal translucency, which is this little area it goes from the back of the head all the way down to the lower back. And we're looking for the thickest part of that along with the blood work. So it's a combination of that nuchal translucency measurement along with the blood work that is going to give us the best screen in the first trimester. And then in the second trimester, from 15 weeks to 20 weeks, 6 days, we're going to do blood work along with an ultrasound. So the first trimester screening was designed for pregnant women in the low risk category. But almost every woman wants to have that screening done, even if they're already in the high risk. They want to take the avenue of looking at blood work first instead of having an invasive test. So screening in the high risk women, first, second trimester screening is not a substitute for amniocentesis. So, some of these moms do get a little bit false reassurance when all of their blood work, all of their scans come back negative. But they still you got to remember, we cannot diagnose karyotype, the chromosome abnormalities on ultrasound. We can get suspicions that there is a problem, but you cannot tell the genetic makeup of that baby. So most of the screening only provides a risk assessment for 3 of the chromosome abnormalities, and some of the newer NIPT goes further than that. And screening is going to miss about 10% of Down syndrome. Normal screening only suggests a lower risk. It gives us a risk assessment, but it's not a guarantee. So The maternal serum screen that we look at is the maternal serum AFP, the triple screen, the quad screen, and the penta screen. So the AFP alone is just looking at the alpha-fetoprotein levels. Triple screen is using 3 of the analytes, the quad 4, and then the penta 5, and we'll go through each of those. One of the newer tests that we have out there is the NIPT, which is non-invasive prenatal testing, and that's actually looking at the fetal cells, the fetal DNA within the maternal serum. Then looking at the nuchal translucency, and then the genetic sonogram, which is looking at the detail, the targeted scan, looking for specific markers that we can see with some of these babies that have aneuploidy. So this looking at, I know it's a busy chart, but it's giving you each of the screens. When would we draw it? What is their Downs risk and trisomy 18 pickup detection rate, and then open neural tube. So it's giving you all of these tests and what their risk assessment, and how accurate are they? And when would we draw them? And so in the first trimester, you're going to do the nuchal translucency, and then it's looking at the PAP-A and the beta-HCG. The sequential screen is a 2-part test where it's actually looking at the first trimester and a second trimester blood draw, and then gives you a result after both of those are done. And then just the maternal serum AFP, and then looking at the triple screen, which is looking at the analytes of the AFP, the HCG, and the estriol. And then the quad or tetra, which is going to add in the inhibin, and then the penta, which is adding in the HCG. So at least this is showing you what analytes are being looked at, and then what is their accuracy rate. So the non-invasive prenatal testing, again, is the newest kid on the block. That's our cell-free fetal DNA. It's found in the maternal plasma. It's a technique called massively parallel sequencing to sequence, or MPSS. And it looks for an over or an under representation of a specific chromosome. There's 4 main labs that started this. Sequenome, which did the maternity 21. Then we did the Veronato for the Verify, LabCorp, which did Harmony, and then Natera did Panorama. So there's different labs that have patented their different tests. So the first 3 tests were only done on the high-risk population, so some of the results were a little bit skewed as to how accurate it was. And then the Panorama test was the only one that was designed for women of any age. So you got to remember, month by month, these lab screenings are getting better, so it's changing. You need to make sure that you keep up to date with those. So first trimester screening is a combination, again, of the biochemical markers, which was your free beta-HCG and your PAP-A, and then the ultrasound marker, which is the nuchal translucency. And so that's also known as the early screen or the ultrascreen. Again, each lab has a little bit different name as to what they call it. And what we're really looking at are these 3 things. So the free beta-HCG, the PAP-A, and the nuchal translucency. So what the screen is positive for Down syndrome if you have an increase in the beta-HCG, a decrease in the PAP-A, and an increase in the nuchal translucency. Where with trisomy 18-13, there's a decrease in the beta-HCG. The other 2 are going to be the same. So this is the main one that's different from the trisomy 21 versus the 18-13. So the free beta-HCG is a placenta-derived glycoprotein that consists of 2 subunits, the alpha and the beta. It's the most specific and sensitive biochemical marker for Down syndrome and trisomy 18. It's increased in women carrying a fetus with Downs and reduced in a fetus affected with trisomy 18. The PAP-A, on the other hand, is produced by the placental trophoblast, and it's significantly reduced in women carrying a fetus with Downs and or 13-18. Some of them are just doing a draw from the arm. Some are doing a little finger stick. So it's what lab you set up with what the procedure is. So then we're going to look at the nuchal translucency. So it goes from the middle of the head to the middle of the back, and what we're looking for is this thickest part. And in early embryology, every little embryo has this. It's just how thick is it? So there's certain guidelines that we need to follow. It needs to be in a neutral position. It can't be hyperextended or hyperflexed. You need to make sure that it's away from the amnion. And it has to be that neutral position, looking straight up. We try to look at the nasal bone if we can. And again, making that separate from the amnion. Sometimes those babies are laying right on the amnion and you think it's really thick. But when the baby moves away, then you can see that, nope, that was the amnion. So you have to make sure that you are able to get that embryo to move away from the amnion so you get a good, accurate measurement. So we're going to do a crown rump length along with that NT. You're going to magnify your image. It's in a true mid-sagittal plane. You want the transducer parallel to the nasal bone, and you're going to measure it on to on. So again, looking from the middle of the head to the upper back, we look along this whole area here, and we're looking for the thickest part of that nuchal translucency. So we want to make sure that's not too flexed. Look how that chin is tucked down to the chest. Well, then you wouldn't want to do your NT there. I mean, this screen is very accurate, but you have to follow the guidelines. You have to make sure that you're getting a good, accurate measurement. So we can see right here, this is amnion. So this is your NT right here, but we still wouldn't use that one because look how tucked the chin is. Or this one, now the baby's hyperextended. That little chin is pulled up too high. So if there's too much flexion or too much extension, then we do not want that. We want that nice midline, neutral position. So we want to see the chin just elevated a little bit, and then we are going to measure the widest portion here. And the NT varies with crown rump length and gestational age, so just be aware of that. There's 95th percentile will change as you go along. The earlier you do that NT screen, sometimes a 2.4 may be at the 95th percentile. But any time that NT is greater than 3 millimeters, that is going to give you increased risk for other problems. So it can be syndromes, cardiac defects. So there's a whole laundry list of other things that it could help us try to identify. So increased NT can be seen in chromosome abnormalities, cardiac defects, genetic syndromes, skeletal dysplasias. It can give us a risk, letting us know that maybe this pregnancy is going to have problems later down the line. And then a discordance in the NT from your monochorionic twins can be your earliest marker that can be seen for twin-to-twin transfusion syndrome. So if you're doing monochorionic twins early on and you see a big discrepancy in the NT measurements, they really need to be monitored closely to make sure that they're not going to be one of those pregnancies that develops twin-to-twin. I mean, look at this laundry list of different things that can be associated with just an elevated NT measurement. I don't think anybody would miss that this one doesn't look normal. So 12 weeks, 4 days, we did our crown rump. But I mean, look at this. You even have tissue edema along the anterior abdominal wall. And so this is a pretty extensive increased nuchal translucency. So at this point in time, if you're scanning and you see this, then the physician, the genetic counselor would come in and they're going to, offer CVS to this patient. Because, I mean, this is abnormal. So we know the lab value is going to come back abnormal. So then they just move on to the invasive procedure at that time. So ACOG does not recommend using the NT measurement by itself to screen for Down syndrome because it's just not as accurate. You want to make sure you're using the NT, nuchal translucency, along with the biochemical marker. So our detection rate went from 82% to 91% by making sure that we're including that lab value in there. All right, so other documentation. You want to make sure that when you're doing your NT screen that you're documenting the presence, absence of the embryo in the yolk sac. You want to measure the yolk sac if you can, because sometimes an abnormal yolk sac, either in the outline of the yolk sac or the size of it, can give you an indication that there might be complications in this pregnancy. You want to identify the number of embryos, presence or absence of cardiac activity, doing that crown rump length measurements, and then presence or location, size of any fibroids or adnexal masses. So usually when you start scanning, you want to make sure you're doing a little survey of the pelvis, looking at the uterine wall, all the way over to the adnexal areas, both to the left and the right, and document that you've looked to make sure that there's no large masses or fibroids that may be seen in a pregnancy. You always want to be screening for that. All right, so the genetic sonogram. So we're going to do everything that you do in your standard scan, and now we're going to add other things. We're going to look for any major abnormalities, any markers, and we'll go through each of these markers individually. And then how many of these markers do I see? And we're going to make sure we're paying attention to the details of the hands, the feet, the chin, the profile, and then the posturing of the hands and feet. So our major markers are if there's any increased nuchal thickening or nuchal fold, heart defects, or any other anatomic defects. Your minor markers are short long bones, short nasal bone, choroid plexus cyst, echogenic foci within the heart, echogenic bowel, pylectasis, dilated renal pelvis, or hand and feet abnormalities. So it's looking at all of your basic anatomy, but then looking at the detail. So we want to make sure when we're doing our survey that we have enough depth and penetration to penetrate the whole uterus, but then when we go to these minor markers, we want to make sure we're magnifying up at each area individually to try to pay attention to the detail of each structure. So there are many normal variants that are not structural abnormalities. They're common in the normal fetus, but they're more common in aneuploidy fetuses and more common in trisomy 21 than structural abnormalities. An ultrasound is only going to pick up about 50% of your babies with Down syndrome because only 50% of them will show us something on ultrasound. So we try to pay attention to the different markers that are available to us. So only one marker is found in about 10% of normals and approximately 25% of your babies with Downs. An isolated marker increases your risk a little, but it really does increase the anxiety of the patient. So you have to be able to have your physician or your genetic counselor, if you have one available, be able to chat with them, explain what does this mean, what type of follow-up do I need, what are my options, what other screens are available for me. So the implications of only one marker in a low-risk population remains unknown. Some of our limitations to that genetic ultrasound is if the gestational age is too early or too late, suboptimal imaging secondary to the maternal body habitus or the fetal position, and then anytime we have too much or too little amniotic fluid, especially the too little amniotic fluid. If you're really struggling to see things, do an evaluation of the fluid. Old or bad equipment, just because the detail on the older machines are not as good, and then just the lack of the sonographer or the sonologist's expertise. So what are some of these common aneuploidy markers? Well, choroid plexus cyst, the nuchal thickening or nuchal fold, echogenic bowel, short femurs and or humerus. How many people are measuring the humerus? Humerus is a more sensitive marker for Down syndrome than what femur is. So I really would want you to go ahead, if you can, try to implement that into your protocol. Then looking at the renal pylectasis, when you have the renal pelvis, if it's greater than 4 millimeters, the echogenic intracardiac focus, hand posturing, anatomic defects, and then the single umbilical artery. Okay, the problem with the common markers is that they apply to more than one genetic abnormality, and then they can be seen in the normal fetus. So just because you see one of these markers doesn't mean that that baby definitely has aneuploidy, it just increases the risk. So the nuchal thickening and nuchal fold was first described in 1866. So it's one of our first ultrasound markers that we could consistently say was associated with problems. It's universally used, it's very sensitive, and for ultrasound, very sensitive means 20 to 40%. Not as good as what our serum screening is. So it can be seen in association with heart defects and other abnormalities. So just because you have an increased nuchal fold doesn't mean that that baby has Downs. It means that it has an increased risk for a problem. And you can see this in normal fetus. So what is that nuchal thickening or fold? It's a redundant skin at the back of the neck. It's measured at the level of the cerebellum with the cavum septum pellucidum in view. So here's a cross section of our head. We want to be able to see the cavum septum pellucidum with the falx. And then as we go back to the posterior fossa, you should be able to see the cerebellum, the vermis, cisterna magna, and it's at this level. So you try to get it so that this is as perpendicular to your beam as possible. And we're going to measure from the outer skull to the outer skin thickness. So it's an axial section of the head and putting the calipers outer skull, outer skin edge. So abnormal from 14 to 18 weeks it's gestational age dependent. So it's greater than or equal to 5 millimeters from 14 to 18 weeks. And then from 18 weeks to 20 weeks, 6 days, it's greater than 6 millimeters. So looking again at an axial or transverse view of the head, and at the falx, back to the cerebellum, here, there's the skull. So we're measuring from the outer skull to the outer skin. Okay, so fetal nasal bone is now considered as sensitive as the nuchal fold. The absent nasal bone reported to be 70% sensitive for Down syndrome in the first trimester. So that's pretty powerful compared to, 40% that we were getting with the nuchal fold. It's usually seen by 12 weeks. In the second trimester can be short or absent, and then it drops down to the 40%. So now we're back to the same sensitivity as what we got from the nuchal fold. What's good about the nasal bone is when you have these other genetic markers that you're looking at after 21 weeks, nobody really knows, how sensitive. We know it's not sensitive enough to give them a new risk assessment just based on those markers. But the nasal bone is one of those things that you can measure throughout pregnancy. It's gestational age independent. So if you have a late prenatal care, the first time that you see them is when they're coming into your lab at 28 weeks. Well, a lot of the other minor markers you're no longer looking at. Nasal bone is one of the things that you can look at. So you're doing your biparietal diameter, you're dividing it by the nasal bone, and you're getting a percentage. So this is one that really helps a lot when you've got late prenatal care and you're trying to look for any of these markers. So again, that BPD nasal bone ratio, independent of gestational age and maternal age. It's been a very good marker for us. So from 11 to 14 weeks, what you're looking for is just presence or absence. Do you see it or do you not? In combination with maternal age and nuchal translucency can increase your sensitivity to 85%. From 15 to 20 weeks, we measure the length, shorter and downs, again doing that BPD nasal bone ratio, and actually this can go to 40 weeks. It's more sensitive if we use 9 as our cutoff, but then we were getting too many of the normals, so they bumped it up to a ratio of 10, and it detects about 81% of your downs and 11% of the normals. So that's why we're using 10 as our cutoff. And what we're going to do is we're going to get a nice little profile, and we're going to look at nasal bone right here. And remember, it's paired. There's 2 nasal bones, so you want to look for the longer of the 2. And here on this baby, you can see how the forehead's a little bit flatter, but now I'm not seeing the nasal bone. You want to be able to see the skin and then the nasal bone underneath. So you want to make sure you're in that mid-sagittal plane where you can see cavum, septum, pellucidum. If you have too much of the lateral ventricle, you can be off to the side, actually looking at part of the orbit and calling it nasal bone. So it's important that you are in that mid-sagittal plane. Okay, so we're going to look at some of the different features for the different chromosome abnormalities. We'll start with Down syndrome, or trisomy 21. The highlight ones for this syndrome is going to be the increased nuchal fold and the absent or short nasal bone. But then shortening of the long bones. Remember, humerus is more sensitive for Downs than what femur is. The brachycephaly, which is that little short round head. The echogenic foci, congenital heart defects. Clinodactyly, which is a little curving in of the pinky. It can be any of your digits, but it's more common on the pinky, because you have a short or a missing 5th midphalanx, so that causes that little curving in. Duodenal atresia, but remember, duodenal atresia, we're probably not going to see that until after 26, 28 weeks. Hyperechoic bowel, ventriculomegaly, pylectasis, the flat facies, and the sandal gap toes, and we'll go through each of these. Things we look for in Edwards syndrome, which is trisomy 18, the clenched hands, abnormal posturing of the hands, and then multiple large chorial plexus cysts. They also have an association, again, so this is where you're going to start to see the overlap between the different abnormalities. So the congenital heart defects, IUGR, rocker bottom feet, radial ray anomalies, clubfoot, strawberry-shaped head, we'll go through that, cystic hygromas, polyhydramnios, single umbilical artery, omphalocele, neural tube defects, diaphragmatic hernias, agenesis of the corpus callosum, a small chin, and then ocular anomalies. So this goes along more with your trisomy 18. And then for trisomy 13, the big one will be the holoprosencephaly and the polydactyly. So the top ones are the highlight hallmark abnormalities that you see associated with that chromosome problem. But again, here's where they overlap: the cranial defects, facial defects, microcephaly, EIF, neural tube defects, IUGR, ocular anomalies. So you can see how they overlap: the hygroma, the omphalocele, ventriculomegaly, and single umbilical artery. And then with Turner's, cystic hygroma and lymphedema are your 2 main hallmark signs for that. And then the heart defects would be a coarctation or bicuspid aortic valve, IUGR again, horseshoe kidneys, so again, more renal abnormalities, bone dysplasia, fetal tachycardia, single umbilical artery, high drops, and short stature. Triploidy, the first thing we see is this early onset of IUGR. Syndactyly, where you actually have the webbing of the digits. It's more common in digit 3 and 4. And you can just have a tissue webbing, or it can actually be the bones that are fused. The ones that they share with other chromosome abnormalities, this is the single umbilical artery, the prominent forehead, cleft lip and palate, small chin, omphalocele, dysplastic cranial bones, hypertelorism, so wide-spaced orbits, asymmetrical development, macroglossia, low-set malformed ears, microophthalmia, so small lens of the eyes, and abnormal placenta. How many people are looking not only just for the orbits, actually looking for the lens of the eye? Yes, if you can. I mean, you're looking at the orbit, so just angle around so you can see the lens, because congenital cataracts go along with trisomy 21. So we are looking for that. You should just see the nice little round area of the lens. So I mean, you're identifying that, yes, there is something within that orbit. We do see an eye there. And then cystic hygroma. So now we're going to go through some of these abnormalities, what they're all associated with. So you can see trisomy 13, 18, 21, triploidy, and normal fetuses all can have a cystic hygroma. The larger the hygroma and the earlier you see it, the greater the chance that it's chromosomally abnormal. In that first trimester, the most common would be Turner's, and then 21. But we're looking at, this is the back of the head. This is all this little septated cystic dilatation at the back of the neck. Here we're looking from the little tush to the anterior abdominal wall to the head, and again looking at this hygroma. So it's dilated lymphatics is what we're saying. So cystic hygromas affects about 21% of fetuses with Turner syndrome. Again, looking at that edema, that tissue edema. Usually large, septated, may regress in size. So just because they're dilated in the beginning doesn't mean that's going to stay that way. Almost all of them will regress a little bit. But anytime you see tissue edema or hydrops associated with this, then the prognosis is decreased. Anytime you have hydrops that develops, then those babies don't do as well, and it increases their risk for aneuploidy. So it's looking at the head again, down into the chest and a little bit of the abdomen. You can actually see a little bit of a pleural effusion here. Again, that tissue edema, and then on either side of the neck, we can see these dilated lymphatics. Choroid plexus cysts are present in approximately a third of fetuses with trisomy 18 and present in trisomy 21 at approximately the same rate as what we found in normal fetuses. It used to be when we started looking at the choroid plexus, we were saying, oh, this is abnormal. Well, then the better equipment, we're seeing them more often. We're finding that it is pretty much the same as what it is for the normal population. We see them a lot. So if you see it as an isolated defect and nothing else, it's we just consider it a normal variant, because we follow these after they were delivered, and that we've never found any other problems as long as that was the only thing we saw was that choroid plexus cyst. So ventricular megaly is usually mild, so greater than 10 millimeters, and throughout pregnancy it's 10 millimeters. Both the ventricles and the cisterna magna should be less than 10 millimeters. And where we're going to measure that is right at the posterior horn of the lateral ventricle. So where you're going to see the glomus of the choroid plexus, that's where we're going to measure the distance of the lateral ventricle. But you can see these can be associated with 13, 18, 21, and some of your triploides. So you can see a lot of these overlap from one to the other. So as you start looking at your baby, the more markers you see, you write them down and then try to figure out which one it most likely is going to be, but you're still going to need, CVS or amniocentesis is going to be telling you the karyotype. We can suspect with ultrasound and have a good idea, but again, it's not giving us a diagnosis. So brachycephaly is that abnormal head shape, lemon shape or strawberry shape. So the brachycephaly is when we have that short round head, because a normal head should be nice and oval. So the strawberry shaped head is just kind of curved in a little bit here, but really round. And the strawberry shaped head is more common with your 13 and 18s. Enlarged cisterna magna, again, greater than 10 millimeters. So if you remember nothing else, 10 millimeters for the ventricles and cisterna magna in the baby's head. You can have agenesis of the corpus callosum and then a small cerebellum. So what is the one measurement that is pretty consistent with gestational age, regardless of what else is going on in the pregnancy? Cerebellum. So really look at that measurement. It's usually pretty accurate. If you've got a 21 millimeter cerebellum, that baby's range, for gestational age would be 20 to 22 weeks. It's pretty accurate. It's one of the last things to be affected by other factors. All right, so small cerebellum in the 13, 18, and triploidy, and everybody know how to look for agenesis of the corpus callosum. that mid-sagittal plane where you're looking, you want to get that parasagittal where you're looking at the cavum septum pellucidum, and then you should be able to see the corpus callosum right above there. And if you're having a hard time seeing it, turn on your color and looking for the paracolossal artery. If you see it not following along the corpus callosum going off, then that's a good sign that there's agenesis or a dysplasia of the corpus callosum. So neural tube defects. So you can have meningomyelocele in about 20%, Dandy-Walker malformations, and encephalocele, especially with 13 and 18, they're more likely to have neural tube defects. Achogenic intracardiac focus, probably one of the more controversial markers, that along with the choroid plexus cyst, the bane of our existence. Best seen with the apex of the heart towards the transducer. It's found in about 3 to 5% of normal fetuses. It's more common in the Asian population. It's usually a single focus, most likely on the left side, more commonly on the left side. And the recent studies indicate increased Downs risk if on the right side or bilateral. Again, that's up for debate depending upon who you want to follow in the literature. The pathology of this is just a mineralization of the papillary muscles. It's found again in 3 to 5% of normal fetuses and more common in trisomy 13, and it's usually bilateral with 13, multiple and bilateral. But you can see them 13, 18, 21, and normal fetuses. So it's looking at a cross-section of the chest. So we have our spine here, we have our anterior wall here, apex of the heart pointing towards the left. And when we're looking here, so right ventricle with the moderator band, looking at the left ventricle, and you can see 3 to 4 little echogenic foci in that left ventricle. So again, more common on the left. So we would go ahead and we would do a fetal echo on this then, just because of the multiple echogenic foci, and then go through history, offer any genetic screening. But the first thing we do is look for other things. What else do we see? So heart defects with trisomy 21 affects approximately 50 to 60% of your babies with trisomy 21 are going to have a heart defect. So this is our best clue that there might be something going on with the baby. The most common of these defects for the trisomy 21 is going to be AV canal defect, where the whole crux or center of the heart is gone, or a VSD. So in trisomy 18, the most common heart defect that we see is a VSD. It affects about 80 to 95% of babies with trisomy 18. And then with 13, again, 80 to 90% will have a heart defect. And the most common heart defects we see with that will be the hypoplastic left heart and VSD. And then those echogenic foci found in 20 to 40% of fetuses with trisomy 13. So again, the more things you see, the greater the chance. But you see how out of all these chromosome abnormalities, what's the most common thing they have in common wrong with them? Heart defects. That's usually our best clue that something else is going on globally. Turner syndrome, approximately 20 to 50% will have a heart defect. Coarctation is the number one thing that we see in association with Turner syndrome. And then you can have aortic valve abnormalities. So when we look at the hands and the feet, we look at the hypoplastic fifth mid-phalanx. So this is the way your fifth should look. They should all be pretty equal. But sometimes you can have an absent fifth or the little curving in of that digit. Now, clinodactyly can be, a normal variant also. You can see it in the normal population. It's just, again, one of those markers that we look at. The other thing we look at for trisomy 21 is the gap, or the sandal toe gap, between the first and the second toe, because you have some syndactyly, so some webbing between the second and the third toes, which causes that wide gap between the first and the second. Now, you can have babies that do this and then go back to normal posture. So you can't just take one clip and say, oh yeah, they've got the sandal gap toes. It has to be something where it's always like that. It's not just baby moving the toes and then going back to normal. So you do have to look at it over time. Okay, the clenched hands, high association with trisomy 18. You have the overlap digits, arthrogryposis, the curving in of the wrist. And usually because they may have a shortened or a missing radius, and that causes some of that abnormalities of the posturing of the hands. So not just looking for the hands and the arms, maybe looking at how the baby's holding the hands. When they're moving around, how are they holding? They should be able to open and close those hands and move them around normally. I think when it's coming out straight like this and it's always fixed in that position, that is not normal. And then the overlapping of the digits. And then with trisomy 13, again, the limb abnormalities, and the more common one that we see is going to be polydactyly. So an extra digit, and remember looking at both the hands and the feet. It's more common to be post-axial polydactyly, which is going to be on the pinky side. Pre-axial is over by the thumb, but you can have polydactyly along any of the digits. These are just the more two common sites. So when you think that there might be an abnormality, then you just go ahead and start counting. You know, how many toes do I see? How many fingers do I see? But that, along with a round head and a heart defect, that would lead you more towards a trisomy 13. Foot abnormalities that we can see with 18 and 13 are club foot, rocker bottom foot, and then just posturing of that foot when it moves. Again, not moving the foot normally. Abnormal posturing of the thumb. And then triploidy have syndactyly, the third and fourth fingers, abnormal limb posture, and high association with club foot. You should never be able to see that tib fib on the same plane as you're seeing the bottom of the foot. So you want to look at assess the legs both in a profile of the leg and then looking at the AP, looking the tib fibs coming down, and then you should not be able to see the foot on the same plane as that tib fib. So single umbilical artery. Just when you're looking at this, we want to look at it, either floating in the amniotic fluid, and then we want to look at the cord insertion into the baby's abdomen. So there's two different sites that you're going to document there. You want to be aware not to go too close to the placental insert because sometimes you can have those two arteries that fuse together right before they go into the placenta. So when we look at our baby, we're going to do a cross-section of the pelvis, find the bladder, put on your color, and make sure that, how many umbilical arteries do I have. You're going to have an umbilical vein, so otherwise you wouldn't have a live baby, so it comes down to how many arteries do I have. Okay, so fetal hydrops can be seen with 13, 18, 21 Turners. And one of the main reasons for that is because look how many heart defects they have. Anytime you have a bad heart defect, then that increases your risk for hydrops. Omphalocele, again, affects about 1 to 5% of your babies with trisomy 21, about 10% of your trisomy 18. And this is one of those things where bigger is not always worse. The larger omphalocele sometimes can have a lower association with chromosome abnormalities if that's the only thing you see. And the smaller defects actually have a higher association with chromosome abnormalities. So just this little bit of the bowel herniated right into the base of the cord. So you want to make sure that when you're looking at your cord insertion that you can see amniotic fluid on both sides, that you're actually looking at that anterior abdominal wall to make sure that there's no little omphaloceles there. So this is a baby that had trisomy 18. Many are miscarried or die in utero. 90% of the affected newborns die within the first year of life. Trisomy 13 affects approximately omphalocele seen in about 18% of the babies with trisomy 13, and about 1 to 5% of your babies with triploidy. So these are just different presentations of omphaloceles. So the early onset of asymmetrical growth is another marker that we can see. You see that with 13, 18, triploidy. Growth delay secondary to the placental maternal problems. That's usually present in the late second and early third trimesters. So some of the other markers that we look at for Down syndrome or trisomy 21 is a wide pelvic angle, small ears, brachydactyly, so little short fingers, the protruding tongue, pericardial effusion, and then unfused amnion and chorion after 14 weeks. And I'm not just talking a little bit of the amnion chorion. I mean, the whole amnion is not fused. So that can be one of your earliest markers too that there's something going on. All right, so looking at the short long bones, there's a large overlap with normals. Short humerus, again, is more specific than short femurs for Down syndrome. Results vary from gestational age, race, gender, family history, and height. The further you get into the pregnancy, the less accurate the short long bones are going to be. Unless your long bones are less than the first percentile. If you're measuring your humerus and your femur and it's less than the first percentile, then you need to measure all the long bones, radius, ulna, tib, fibs. Then look at the ribs, look at the scapula. All of those can go along with skeletal dysplasias. All right, so most often used criteria is if it's less than the 10th percentile for gestational age. That's one of our markers. Or we can actually do an observed or over expected. So there's actually a chart that tells you what the expected length is for that gestational age, and then you compare it to what you actually measured, and it'll give you a ratio. The renal pelvis, dilated renal pelvis, is when, again, is greater than 4 millimeters. It's measured in your AP dimension, occurs in about 3% of normal fetuses, is more common in boys than girls, and it is a weak marker, one of our weaker markers. But this is how we're going to measure that. Transverse of your abdomen, spine up if you can get it that way, and then measuring the renal pelvis. So right where that central collecting system is coming together and then exiting the kidney. Hyperechoic bowel is nonspecific, non-structural. It's a focal area of bowel that looks as bright, equal to bone. So the way you check this is you turn up your overall gains and you slowly start to turn them down as you're watching. If you lose the bowel echoes before the bone, then it's not as bright as bone, so you don't call it. It's found in about 0.5% of normal fetuses. It can also be associated if there's been a history of vaginal bleeding. If there's bleeding into the amniotic fluid and the baby swallows the amniotic fluid, that can cause increased echogenicity to the bowel. It can be associated with viral abnormalities, infections, and then also cystic fibrosis. So, I mean, there are different things that can be associated with the echogenic bowel, the hyperechoic bowel. Bowel atresias, congenital infections, CMV, toxoplasmosis, parvovirus, cystic fibrosis, swallowed blood, growth delay. If it's bright enough to catch your eye, then go ahead and make sure that you do that little test of, do I see it at the same time that I'm losing my bone echogenicity? Protruding tongue, so we can see how the lips are even held open. This tongue never was able to go back into the mouth. And then pleural effusions. And we used to do iliac angle. We used to try if it was abnormal, if it was greater than 90 degrees. But technically, it was difficult to do, just like the cheek-to-cheek measurements we used to do. There's some of these things we used to try that we don't do anymore. I just thought I'd put it in there that is one of the other things we used to look at, is look at the iliac angle. We used to look at brachydactyly. We would do a digit length quotient, so you're looking at a transverse of the hand diameter over the length of the digit. And again, we can't always get that baby to open the hand, so it was one of those things that we just don't spend enough time. Not every baby's going to open the hand, so it wasn't very effective for us to use that as a marker. And then low set ears. Well, how do you tell if they're low set ears? Well, on the sagittal and transverse imaging of the head, if the top of the ear is below the level of the middle of your orbit, your ear should come right to the middle of the orbit. So if it's below that, if the top of your ear is below that, that's low set ears. So you want to get a transverse or axial of the head and look at it both sagittally and transverse. Duodenal atresia, again, usually doesn't present until after 24, 26 weeks, so it's not one of those markers we can use early on. Looking at trisomy 18, so there's 47 chromosomes. The occurrence is about 1 in 3 to 5,000 live births. They have a high association with third trimester complications and death. They have fetal distress and labor. All of them have some type or form of a mental handicap, and over 100 defects reported in all different organs, and 90% of them are going to die again in that first year. Other abnormalities with trisomy 18, the meningocele, about 20%, Dandy-Walker malformation, encephalocele, and absent gallbladder. How many people look for the gallbladder? You're looking for the stomach, so I mean, it's usually, you can see it, probably about 90% of the time you can see it. So again, another little marker that you can look at. So polyhydramnios, again, I think anybody from across the room can see that there's just too much fluid around this baby. And look how it even starts to thin out or flatten that placenta. So polyhydramnios seen in about 25% of your cases with trisomy 18. Diaphragmatic hernia is found in about 10% of these babies. So when you're looking at, I like to do the coronal of the abdomen because you're looking from the chest all the way down to the pelvis. It gets you a good look from the diaphragm, the liver, the bowel echoes, all the way down to the bladder. Make sure that the stomach is below the diaphragm where it should be. You'd be surprised how many people will call the gallbladder the stomach and the stomach's actually up in the chest. So make sure that you know that there are two hypoechoic structures in the abdomen and you do identify both of them. So this is looking at a transverse of the chest, and we see the first clue was that our cardiac axis is off. You can see that the heart was pushed over towards the right side. Apex is still pointed towards the left, so it's a dextral position where that heart is pushed over into the right chest. And then this was stomach here. And that was that on a sagittal. Again, here's the heart being pushed, and the stomach was herniated up into the chest. Facial abnormalities, so the micronathia, microophthalmos, hypertelorism, so the wide-spaced eyes, the cleft lip or palate, and then the low-set ears again. The single umbilical artery, and sometimes they can have these cord cysts. This is all a cord cyst here. Some of the biochemical markers detect about 80% of these babies. They're going to have a low AFP, HCG, and estriol. All of those analytes are going to be low. I can see that baby has an omphalocele. Look at this cord cyst. Look at the feet, and look at the posturing of the hands. That arthrogryposis, that posturing of the hand that way is one of the hallmark things that we see with trisomy 18. With trisomy 13, 47 chromosomes, again about 1 in 5,000 births. Survivors have profound mental retardation, seizures, failure to thrive, and visual and hearing defects. One of the hallmark things we'll see is the holoprosencephaly, so those midline defects. So abnormalities of the brain, abnormalities of the face, renal abnormalities, cleft lip, palate. So you can have a midline. Anytime you have midline defects, start looking for other midline defects. The more you see, the greater the risk associated with a chromosome abnormality. Coronal view, looking at the lower lip and then the upper lip up into the nares. So we see this defect that's midline and off to the side. And then on the sagittal and that parasagittal, when you're scanning through, you can see the defect. Brain abnormalities, again, is the holoprosencephaly in 40% of these babies with trisomy 13. They have a fused thalmi, and you have a monoventricular system. You can also have just ventriculomegaly. You can have an abnormal posterior fossa, and again, the microcephaly, or that strawberry-shaped head. The facial abnormalities that we see with 13 are going to be hypotelorism, cyclopia, where you have just a fused or one orbit, one eye. Proboscis, where you have this little snout type thing that you'll see coming off the middle of the face, and then again the low set ears. You can have sebocephaly, absent nose, micronathia, and then this posterior encephalocele, and then the spina bifida, some different bifidas, whether it involves just the meninges or if it involves the cord and the meninges. Gonadal abnormalities. So usually by about 27, 28 weeks, you can see the testes start to descend into the scrotum. So if you have undescended testes after that, just document it. Sometimes they'll come down later. Sometimes they don't descend until after the baby's born. Sometimes they have to be surgically descended. So if when you're looking, I mean, after that you're 27, 28 weeks, start documenting whether or not you can see those testes in there. Trisomy 13, 50% have IUGR, polyhydramnios again in about 15%, but then oligo in 10%. So you can see, look how difficult it is just to evaluate this head. So the first thing you think of is, okay, I have no fluid. Anytime you have a hard time seeing, start measuring, see how much fluid you do have totally. So then this is a baby with trisomy 13. 80% again are going to die within the first month of life. Biochemical markers usually are not very helpful for screening for trisomy 13. Some of our analytes, when they come back, if there's an increased risk for both Downs and 18, it's probably a 13. Have you seen that come back where you have the increase for both Downs and 18? Yeah, we've had that a couple times now where it comes back and they actually ended up having 13. So Turner syndrome is a missing chromosome, missing sex chromosome. Again, about 1 in 5,000 births account for 20% of our first trimester losses. There's a paternal link. It's not related to maternal age. So this is one of the few that's not related to maternal age. It's usually a paternal link. So 45XO. You have the hydrops, lymphedema, ascites, pleural effusion, and then anasarca. And that anasarca is just the tissue edema over the entire body. You can see how everything on this baby is just edematous. 50% of these babies will have hearing impairment. They have high association. They're infertile, and then occasionally some MR. Renal abnormalities in about 60% of these babies, whether it's a horseshoe kidney, you can see how these kidneys were closely spaced with this little band of tissue connecting them in the midline. Pelvic kidneys, so just displaced in the pelvis, and then renal agenesis, so different abnormalities of the kidneys. The biochemical markers may be elevated if there's a hygroma or hydrops is found. Fetal loss at about 80 to 90% when hydrops is present. I mean, you can see how this baby has anasarca, all that tissue edema, and then this very large hygroma. It has an association, let's see, 40% of liveborns have mosaicism, so only part of the cell line is affected. So then they tend to do a little bit better when only part of the cell line is affected. They have the smaller, short stature, they can have the broad chest, wide-spaced nipples, neck webbing, and early ovarian failure. Triploidy occurs in about 1 in 10,000 live births, 20%. They account for about 20% of your spontaneous first trimester losses. Longest survivors at about 10 months. It's where you have 3 complete sets of the chromosome. And the extra set can be from the maternal or paternal in origin. 70% of the extrapaternal have large placenta and or a partial mole. The extramaternal have a small placenta and severe IUGR. And we follow these with serial beta HCG. So 69 chromosomes with your triploidy. Biochemical markers that we'll see affected would be the elevated HCG levels and sometimes an elevated AFP level. But here this is looking at part of the placenta, so the little cystic areas throughout that placenta. Looks like a little grape-like appearance. These are the little placental cysts, early onset of severe IUGR, and then oligohydramnios. So you can see these little cystic appearance to the placenta associated with triploidy. Classic ultrasound findings are going to be syndactyly of digits 3 and 4. So, summary. So the summary of all this is that genetic sonogram is here to stay. It's about 60 to 70% sensitive in the experienced hands and in your high-risk population. The false positives are the problem because if you have more than one marker, it greatly increases the risk for aneuploidy. And you got to use it in conjunction with the maternal risk factors and then with your lab values. Genetic sonogram never diagnoses or rules out aneuploidy. Ultrasound is good at detecting anatomic defects or abnormalities. So when markers are present, this is the statement that they ask you to use, is that the ultrasound findings are suspicious for chromosome abnormality, and then you list your markers. So back in 2004, there was such a big controversy over what to put down for just your chorioplexus cyst and your echogenic foci. So they came out with these statements from the AIUM that the chorioplexus cyst and echogenic intracardiac focus in women at low risk for chromosome abnormalities, that if it's isolated, so if you have one or the other, then that leaves them in the low risk population, doesn't change them to the high risk population. If you have both of them, well, now you have 2 markers, and that puts them into the high risk. So each of those by themselves would not change you from a low risk to a high risk population. And then this is just some of the websites that are out there for both NT and genetic screening. I like to put that in there.